Hello, assalamu alaikum.
Walaikum Assalam.
How's everyone?
Good.
Good, alhamdulillah.
Alhamdulillah.
Okay, so we'll start now. Hmm. Okay, number 31. Manage competition in healthcare most often refers to A. Healthcare providers administered by competing management companies. B. Healthcare providers competing by type of specialty. C. Grouped healthcare providers competing within a geographic region. And D. Managed care organizations. Okay, when we say manage competition, so it is the policy framework designed to combine elements of market competition with government regulation in the provision of public services, particularly in sectors such as healthcare, utilities, and education. So, what's the best answer here? Anyone?
It's a C group healthcare providers competing within a geographic region.
Very good, Doc Nadim. Yes, that's the correct answer because this one is providing services within specified geographic regions. Okay. What about for the others? So for the letter A, this option is emphasizing management companies, which are not a core aspect of managed competition. While for letter B, this focuses on competition between individual specialties like surgeons versus pediatricians, so which is narrower than the broader concept of the managed competition. While for letter D, managed care organizations, these are often involved in competitive frameworks. So this option is too narrow because I said a while ago, this managed competition refers to a broader concept of healthcare groups competing in specific regions, including but not limited to managed care organization. Okay, so next, number 32. In managed care, the most common form of reimbursement for primary physicians is A. Straight salary, B. Capitation without withholds, C. Capitation with withholds, D. Discounted fee for service. What's the answer for this?
Capitation with withholds.
Yes, it's correct. Letter C. Capitation with withholds. Okay, in managed care systems, primary care physicians are often reimbursed through a capitation model with withholds. Withholds mean to deduct from a payment and hold back. So, under this model, physicians receive a fixed amount per patient per capita for providing care, regardless of how many services the patient uses. So for letter A, it is uncommon in managed care because it does not incentivize the cost control or performance. While letter B, this does exist but is less common. Okay, managed care organizations often use withholds as a mechanism to encourage cost, efficiency, and quality performance. While for the letter D, this involves the paying physicians for each service provided but at a reduced rate compared to traditional fee for service. For number 33, outside the US, most industrialized nations offer which type of health care insurance? Letter A, universal coverage. B, employer pays coverage. C, managed care. D, managed competition. Okay, anyone? Radha?
Universal coverage maybe.
Yes, you are right. So letter A is it is universal coverage. So the rationale for this, most industrialized nations outside the US, these provide the universal coverage, ensuring that all citizens have access to healthcare services, regardless of their employment status or financial situation. For the letter B, this is a primary feature of the US healthcare system. So in this model, health insurance is tied to employment, leaving unemployed individuals or those in precarious jobs without access to coverage. While for the managed care, refers to systems where healthcare providers and insurers coordinate care to control costs and improve quality. And lastly, manage competition. This involves the multiple insurers competing for customers under government regulated conditions. Okay. Number 34. The most basic components of managed care include all except. So we are looking for the incorrect answer here. For letter A, prepaid financing. B, comprehensive services at multiple levels and settings. C, controlled access to services. And D, broad choice of providers.
The broad choice of providers.
Okay. Yes, it's letter D, broad choice of providers, because managed care focuses on controlling the cost. Okay, so this improving efficiency and coordinating care. The broad choice of providers is not a component of managed care. So all this prepaid financing, the comprehensive service, and the control access to services are all basic components of the managed care. Number 35, who is responsible for providing the continuous quality improvement direction? A, facilitator. B, quality council. C, leader. D, team. What's the answer? Dr. Gulam?
Leader.
Okay. Who else has the answer?
C.
Okay, the correct answer is quality council. It is typically responsible for providing direction for the continuous quality improvement, or the CQI. So this group sets the goals, priorities, and strategies for the CQI efforts, while facilitator helps guide CQI activities and meetings, ensuring that the process runs smoothly. So they provide support and expertise, but do not set the direction. For letter C, leader may oversee a CQI team or support the CQI efforts, but the broader direction typically comes from the Quality Council rather than an individual leader. While for letter D is responsible for implementing CQI initiatives and making improvements in specific areas, but they follow the guidance and priorities set by the Quality Council. Clear? 36. You have joined the newly merged Preferred Health, a for-profit integrated delivery system, or the IDS. As Vice President for Quality, you are responsible for re-engineering or otherwise integrating the quality management or quality improvement function across the provider network. So based on your understanding of systems, corporate culture, ethics, quality, leadership's influence, and strategic planning, answer of the following: the measure most indicative of the IDS ability to provide value to its stakeholders are. So the IDS, or the integrated delivery systems, aims to provide a high quality care while controlling costs to deliver value to stakeholders, including patients, providers, and payers. For choices, A, improvements in patient outcomes and reduced cost of care. B, an annual report with a positive bottom line. C, improvements in patient outcomes and patient satisfaction. D, reduced cost of care and competitive pricing.
A, patient outcome. Improvements, patient outcome, and reduced cost of care.
Of care. Yes, you are correct, Radha. Why? Because improvements in patients' outcomes, which indicating quality, and reduced cost of care, which indicates efficiency. So these both are directly reflecting on the system's ability to achieve these goals. So these are the most reliable indicators of the value provided by the IDS. While for the B, C, and D, they're all incorrect, because for letter B, financial performance is important, but it does not directly reflect the quality of care or the value provided to patients and other stakeholders. While letter C, This one is patient satisfaction is an important too, but does not directly indicate cost efficiency, which is critical to demonstrating values in IDS. For letter D, these measures might indicate efficiency but do not address the quality of care, which is essential for providing true value. Number 37. Who is ultimately responsible for the effective implementation of the quality program? A. Governing body. B. CEO. C. All staff. D. CFO or Chief Financial Officer. What's the answer for?
All staff
Okay, who has other answer?
responsible for
Okay, here is asking for the ultimately responsible.
ultimate
Ultimately
response.
responsible. Who has the
Governing body.
answer?
Governing
Governing. Yes, it's governing body. So the governing body, who are these are the board of directors, who are ultimately responsible for the effective implementation of a quality program. So they have the authority and accountability for ensuring the organization's quality standards. Okay, for the CEO, plays also a crucial leadership role in executing the quality program and providing operational support. The ultimate responsibility lies with the governing body, which holds the CEO accountable for all the staff. All staff members contribute to the quality program success, but they do not have the ultimate accountability because their role is to follow the guidelines and standards set by leadership, while the CFO, the Chief Financial Officer, focuses primarily on financial matters. Yes, including budgeting for quality initiatives, but they are not responsible for overseeing the entire quality program. Clear? Okay, for number 38, the principle underlying the selection of an organization-wide quality council is A, one oversight body, B, leadership control, C, one cross-functional team, D, elimination of department service quality control. What's the answer?
one A.
Mm-hmm. Okay, that's the correct answer. It's one oversight body. Okay, so going back to the Quality Council or the Performance Improvement Council, so in here, the one oversight body is the correct answer for Quality Council. Okay, moving on to number 39. As Director of Quality Resource Management for an integrated delivery system, you have been asked to provide information prior to renegotiation of a contract with a national preferred provider network. What data will be most helpful? A. Reimbursement minus charges. Okay, letter B. Reimbursement minus cost. Letter C. Charges minus reimbursement. And D. Charges minus cost. What's the answer? The correct answer here is reimbursement minus cost. So it's letter B. When renegotiating a contract, the most important number is reimbursement minus cost.
Cost.
Why? Because this tells how much profit or loss is made after covering the actual expenses of providing care. I'll give you an example. If a procedure costs $500 to perform and the reimbursement is $700, so how much is the profit?
200.
Yes, exactly. So if the reimbursement is only 400, so there's a how much is loss? If the reimbursement is only 400, there is a $100 loss. So this metric helps decide if the contract is fair and financially sustainable. It ensures the reimbursement rates are enough to cover costs and provide a reasonable profit margin. While for the letter A, reimbursement minus charges, this compares the money received. So that is what you call the reimbursement to the billed prices or charges. So, however, these charges often don't represent the real cost of care, as many contracts include discounted or negotiated rates. This makes this metric unreliable for assessing financial health. A hospital charges, I'll give you an example. Hospital charges $1,000 for a procedure, so which is the listed price or charges. However, the hospital has a contract with an insurance company that only reimburses 600 for that procedure, which is a negotiated rate. So in this case, the charges is equals to $1,000. What the reimbursement here is $600. So what is the difference of the reimbursement minus charges? Reimbursement minus charges. I said charges is $1,000 and reimbursement is $600. The formula
For
is
for
reimbursement minus
minus
charges.
charges.
Yes, that's the answer. So $600 minus $1,000 will give you negative
Negative balance.
$400. So this negative number might suggest a financial loss, but it doesn't reflect the actual cost of providing the care. So for instance, if the hospital cost to perform the procedure is only $500, so they are still making a profit of $100.
$100.
Yes, despite the negative metric. So this shows why reimbursement minus charges is not useful for assessing financial viability because it doesn't account for the real cost of care or the impact of negotiated rates. Clear? For letter C, charges minus reimbursement shows the discount or the amount of bill charges that are not paid. For example, if a hospital charges $1,000 for a service, but it is reimbursed or returned only 600. So the difference is
400.
$400. So this $400 reflects the discount, but it doesn't tell whether the hospital made a profit or loss because it ignores the actual cost of providing the service. So if the cost was 500, the hospital would still lose $100 despite the discount. So therefore, this metric is not useful for evaluating profitability. What about letter D? Charges minus cost. Charges minus cost shows the markup or profit based on billed prices. Like if a hospital charges $1,000 for a service and it costs $500 to provide, the markup is $500. However, this metric is not useful for contract negotiations because bill charges are inflated and do not reflect the actual reimbursement rates. Okay? Clear? Okay. So number 40. According to Total Quality Management or TQM principles, managers should A. Lead with autocratic decision making, B. Communicate successes or failures only to the boss, C. Lead with participative decision making, D. Focus on short term financial impact of quality improvement techniques. What's the best answer?
Participative decision making.
Yes, so it's letter C, lead with participative decision making. Very good. Participative decision making, this involves engaging employees at all levels of the organization in decision making process because it promotes collaboration, communication, and shared responsibilities. Why not A, autocratic decision making? Because
This
this
is
involves,
in cases of um,
yes, involves
big
leaders making
with,
decision without Radha,
without
Tesh?
without the people working, our employees,
Yes,
or
exactly. Without consulting others. So, which is contrary to the collaborative spirit of the TQM. What about letter B? Communicate successes or failures only to the boss is incorrect because in the
yeah.
context of TQM, it weakens the principles of transparency, collaboration, and shared responsibility that are central to TQM. While letter C is focus on short, it can lead to compromising quality for the sake of immediate cost savings, potentially harming customer satisfaction and employee morale. Okay, any question or any unclear doubts or for clarification?
Okay.
Okay. So if none, so we will proceed now to our next topic. Okay, wait, time lost now. Are you all still here?